Mike Gibson, Wayne Batchelor coming to you live from ACC 2026, and we're talking about a new trial looking at automated notifications of people who have severe AS or mitral regurg. Wayne, talk to us a little bit about what you did.
Well, first of all, thanks for having me, Mike. I'm really excited to talk about the ALERT trial. This is a fascinating randomized cluster randomized trial. We are basically interested in understanding if electronic notifications could help us practice cardiology a little bit better with regards to valvular heart disease. So, as you know, aortic stenosis and mitral regurgitation are underdiagnosed and undertreated. It's been reported that less than 50% of patients with aortic stenosis actually get treatment, even based on level 1 or 2 guideline recommendations. So we wanted to understand if a nudge, an electronic clinician notification, might be valuable. There's been one other study, the Detect AS study, that looked at this and suggested that there might be a signal. So we did a large randomized trial that randomized clinicians across 5 healthcare systems and 35 hospitals to be given an electronic notification based on something called Tempus Next software. It's basically AI that can detect aortic stenosis and mitral regurgitation simply from discrete and non-discrete data that's existing in the EHR. And so clinicians were notified either to get an alert or no alert if their patients had an echo that revealed these findings. And we expected there to be perhaps some effect from this based on the Detect AS study. So we actually enrolled a good number of patients. We included over 40,000 echoes that were scanned. And from that, we had about 2016 that ended up having some valvular lesion of interest, either severe aortic stenosis or moderately to severe mitral regurgitation. So they were randomized, and I can tell you we used a win ratio, a stratified win ratio, stratified according to disease. And for our primary analysis, which was a hierarchical endpoint of valve intervention, surgery or transcatheter, or referral to the multidisciplinary heart disease clinic, the MHT, the multidisciplinary heart treatment evaluation. So in the end, we found that the average age of the patients was 76, half were female. This was a more diverse patient population than what we had seen in Detect AS. So we had 80% white and 15 to 16% black, and at least 5 to 10% Hispanic ethnicity. We had a high rate of patients with low gradient aortic stenosis, only because by design, if you already were referred to the multidisciplinary heart team clinic or the valve clinic, you were not included in the study. So this biased us a little bit more towards some of the patients where folks may not have been just naturally referring. So the mean valve area was 0.85 in both groups. The mean gradient was 31, and the peak gradient was on average 51 millimeters of mercury. We found that through the cluster randomization that was performed at the clinician level, a statistic.
The clinician level, not at the
Yes.
site level.
Not at
Interesting.
the site. This has to be based on the clinician, because what we're trying to modify is the clinician behavior.
Uh-huh.
Yeah. Now, so we did cluster randomization, Mike, so that
But
so
let me
that
ask you, Wayne, did they get the same randomization throughout the entire period? I mean, if you were
yes,
randomized to the nudge, you got randomized to nudge the whole time.
the whole time.
Because
And the
sometimes you cross over between nudge and no nudge, to
Correct.
so you
That sort of contamination is a real design challenge for a study like this. So once you were randomized into one arm or the other, you stayed in that arm and you did not cross over. And
it's a multi-nudge thing. I mean, they all kind of got nudged.
well, it was based on the echo. So if there was an echo
Mm-hmm.
that showed this abnormality, we first would go to the treating cardiologist who ordered the echo, and if that could not be identified or there wasn't one, it would go to the primary care provider and then to whomever else after that. So This would be just to one provider based on the echo with that hierarchy going first to the cardiologist.
And what did you see? Did you speed up treatment or improve?
Well, I mean, it was a really interesting finding. A couple things we found in terms of the primary endpoint analysis. We saw that the overall stratified win ratio was 1.24 in favor of the electronic notification, with a p-value of less than 0.001, highly statistically significant. This translated into a 4.4% increase in either valve intervention or multidisciplinary heart team visits from 19.9% in the no alert arm to 24.3%. That's a little over a 20% relative increase. But
But the absolute number, that 4.4, you divide that into 100, you only got to really kind of, apply the nudge 25 times to get one more person treated.
That's a nice way of actually citing the impact, and I completely agree. The time to valve intervention was shortened, and there were more valve interventions in the nudge arm. For example, 13.4% of those patients who were in the alert arm went on to get valve intervention, and only 9.6%. That's a 3.8% absolute increase, but a relative increase of over 40%. So these results were both clinically significant and statistically significant. And it was quite interesting because we did a subgroup analysis, Mike, and looked at how this played according to key subgroups: men, women, different racial and races and ethnicities, social
And AS
demographics.
versus mitral regurg too, right?
Yes, and that's where, and both, by the way, it was significant in mitral regurgitation and in aortic stenosis. So just to
Mhm.
give you some perspective, the win ratio was 1.26, statistically significant for aortic stenosis, but the win ratio was also 1.20 for mitral regurgitation, directionally in the same direction, but because we had more aortic stenosis patients, did not quite meet statistical significance for the R cohort. That we were not powering specifically for.
But the interaction term, I'm sure, was negative, that there was no difference
Exactly.
between
Yeah, it
those
was a
two.
negative interaction term. We found also no heterogeneity of treatment effect across multiple subgroups: age, sex, race, social deprivation, inpatient versus outpatient setting. What was a fascinating finding was, though, there were some differences in how effective the treatment was across different sites of care. So across the five health systems, there was there were differences between certain health systems in terms of how effective the nudge
Hmm.
was. There was a significant degree of heterogeneity there. So
You're kidding me.
fascinating.
Different doctors respond differently.
Different
Who would have
doctors
thought?
respond differently. And remember, I didn't mention it, but the nature of the nudge. So there was basically a message sent to the inbox of the provider who ordered the echo saying, "Hey, you've got a patient with severe aortic stenosis. Consider referring to the multidisciplinary heart clinic or to for further evaluation." But the way in which that nudge was, the wording was according to site. So there was a lot of
Oh,
different ways in wording this across the
ah.
site. So we're going to do some more analysis to understand if there was an effect based on how the wording was presented and how the nudge was presented to the provider.
And
So
do you know the ages of the nudgees who got nudged?
yeah,
You know,
that
so
that's an excellent question. We don't have that data currently. We're going to dig and see if we can get that data, because I think the nature of the provider here is really interesting and critical to understanding perhaps differential effects based on characteristics of the provider. But that's going to be the attention of another analysis for the future. We don't have that. It's, as you can imagine, there were hundreds of providers, a total of nearly 900 providers in the study. So there's a lot of work that has to be done there.
But appropriately, we tend to focus on the patient demographics. But in this kind of study, we also got to focus on the provider too, the person getting nudged. Well, Wayne, that is fascinating. I'm so tired of all of us working for AI, being MD standing for manual data entry. I'm so glad that we're now having technology work for us instead of us working for technology. This was a nice example of it. Congratulations on some great work.
Yeah, thanks, Mike. I think this shows that, a simple AI technology presents itself as a scalable digital health strategy to help us practice better
Correct.
and reduce the undertreatment of valvular heart disease, not to supplant docs, but to just to give us an extra little nudge, so to speak, in the right direction.
Well said. Wayne, congratulations. Thanks for joining us.
Thanks, Michael. Appreciate it.
And thanks to all of you for joining us here live from ACC 2026.